Okay, so in this video I'm going to be looking at the main mood stabilisers used in psychiatry. So first, probably the biggest mood stabiliser used is lithium. It can be used in a multitude of different conditions. For example, it can be used in acute mania, but be careful because lithium can be harmful if taken for less than 2 years. It can cause discontinuation symptoms, which actually include mania, so make the problem worse if not taken for more than 2 years. So it's not advisable to start lithium in a manic patient who is unlikely to be concordant with long-term treatment in the acute setting. It can be also used as prophylaxis in bipolar affective disorder. The indication for this would be if the patient had a manic or hypomanic episode associated with serious adverse risk or consequences to the patient. A manic episode and another disordered mood episode, or repeated hypomanic depressive episodes with significant functional impairment or risk. So really it's used in bipolar but for the more seriously unwell patients. It is important to remember that lithium is tetragenic, so is not advisable to use in women who are planning on being pregnant, and it does require 3 monthly blood tests to monitor levels. And it is probably best to consider another mood stabiliser if the patient has 4 or more episodes of bipolar in a year. It can be also used as augmentation to antidepressants in treatment-resistant depression. It can help control symptoms in there. And it can be also used in adjunct antipsychotics in schizoaffective disorder and schizophrenia, especially when there's aggression and impulsivity, and where there are significant affective symptoms associated. I mentioned before about the blood tests used when a patient is taking lithium. These are to monitor its therapeutic levels. There are 3 categories for this. The first category is between 0.5 and 1 millimole per litre, and this is classed as ideal. If the levels of lithium in the blood are over 1.5 millimoles per litre, then this is classed as toxic. And if the levels are over 2 millimoles per litre, then this is classed as dangerous. As a drug, lithium is taken orally and excreted renally. The clearance of lithium is decreased with renal impairment, such as in dehydration in old age, and in low sodium levels. There are a number of drugs that can increase lithium levels. The biggest culprits are diuretics, especially the thiazide class, but also non-steroidal anti-inflammatories and ACE inhibitors can increase lithium levels in the blood. If patient is taking lithium alongside antipsychotics, these synergistically work together and increase lithium-induced neurotoxicity, so it's important to watch out for these signs in your patients if they're taking antipsychotics alongside lithium. There are a great number of side effects associated with lithium. These include thirst, polyuria, weight gain, oedema, fine tremor, participation or worsening of skin problems, concentration or memory problems, hypothyroidism, impaired renal function, leukocytosis, and cardiac T-wave flattening and inversion. Symptoms associated with lithium toxicity. So between 1.5 and 2 millimoles per litre, patients tend to experience nausea and vomiting, general apathy in their overall mood, a coarse tremor compared to the fine tremor as a side effect of normal lithium, ataxia and muscle weakness. When levels start becoming dangerous, over 2 millimoles per litre, patients can experience nystagmus, dysarthria, a decrease in consciousness, increase in reflexes, oliguria, hypotension, convulsions, and this can eventually result in coma. So management of patients that are experiencing lithium toxicity is generally just supportive, so maintaining good hydration that will allow renal function and electrolyte balance to be maintained. If convulsions are a feature in the patient, then anticonvulsives are advised, and hemodialysis can also be given in case there is renal failure. So it's important to measure use and ease in these patients experiencing toxicity. Before starting lithium therapy, it's important to do a full blood count for a baseline, renal function and electrolytes to get an overall feel about how the patient's kidney function is, thyroid function to examine the thyroid, as a side effect of lithium is hypothyroidism, It's important to do a pregnancy test too, as lithium, as I mentioned before, is tetragenic. It's also important to get a baseline ECG as well to compare things to in the future. There are a couple of contraindications and cautions to lithium use in patients. Shouldn't really be used in patients that are pregnant or breastfeeding, or patients who have a poor renal function, or patients with thyroid disease and cardiac conditions. So that's why we do these investigations before starting therapy, just to give us an idea about who lithium might be useful in. Also, neurological conditions such as Parkinson's and Huntington's, lithium should generally be avoided. As I said before, lithium is the main mood stabilising drug, but there are a number of others. I'll just go through 3 of these and their main side effects. So the sodium valproate, the side effects for this are an increase in appetite and weight gain. Patients also experience sedation and dizziness, with some ankle edema, hair loss, nausea and vomiting. There's tremor. There can also be an increase in liver enzymes. This tends to be quite rare. There are also a number of hematological side effects, such as increased bleeding time, thrombocytopenia and leukopenia. So it's important before starting a patient on sodium valproate to do a full blood count and liver function tests. Carbamazepine is another mood stabiliser. Side effects of this include nausea and vomiting, skin rashes, diplopia, ataxia, drowsiness and fatigue. There is also a decrease in sodium and fluid retention in patients, and there are also hematological side effects such as leukopenia, eosinophilia and thrombocytopenia. Carbamazepine can also increase liver enzymes, although hepatic or cholestatic jaundice is quite rare, but it's still important to check liver function tests and full blood count before starting carbamazepine. Lamotrigine is the final drug I'll talk about. Side effects of this include nausea and vomiting, headache and tremor. The most important to watch out for are skin rashes, and if a patient presents within the first 8 weeks of starting lamotrigine with a skin rash, it's really worth considering withdrawing it, as it is associated with Stevens-Johnson syndrome. Patients on lamotrigine can also experience aggression and irritability, and can also be sedated and dizzy.